Now, two things that are very important and all of you must rely on, that the human beings can never be replaced by equipment. Remember these two. One is the capillary refill time. This is the way on the left to how to assess it. Press for 5 seconds and look for the return of blushing in the nail bed. And you know if it's more than 2 seconds, that's an alarm signal. These are patients to be code red because they have chances of deterioration. This is a clinical parameter and often seldom followed in the ED. There may be issues like nail polish and maybe some nail disease or fungal disease, but nevertheless, it's a very good sign. And the other one is a representation of the AVPU. Easy done within seconds. Alert conscious, V for verbal response, P for painful response, and unresponsiveness. So you have a very rapid scale in which you can triage them very fast, and you know who are the ones who need to immediately be attended to. Now, why do you want hemodynamics? I hope I've convinced quite a few of you, but the reason is very obvious, that 15% of the cases, roughly, again these are Western figures, are going to require it. Emergencies are crowded, ward admissions are little, ICUs are almost chock-a-block. This is the situation of government hospitals. There may be private entrepreneurs sitting here, they may or may not agree with me, but this is the situation as far as my hospital is concerned and what I know of a nearby government hospital. So it reduces mortality by about 42%. Now these are printed figures, these are published figures. It reduces your length of stay in the ED. If you monitor them properly and get them to stabilization or some sort of transport, you may reduce it by a couple of days, and a reduction of end organ damage like renal failure, liver failure, and so on and so forth, and complications as well. On the other hand, it also allows you a rapid assessment of the cardiovascular status, which is critical. You know what you're dealing with, you know how the heart is, you know how much fluid is, what is the vascular volume, what is the lung volume, things like that, and fluid in the lung. It guides diagnosis. Sorry, yeah, I want to go back. How do I go back? How do I go back? I want to go back. Down button. No, it's going forward. Okay, now it's going up. I think please go back. So, back. Yeah, back. Okay, yes, that's it. It guides diagnosis. It targets interventions and treatments in conditions like shock, sepsis, trauma, and heart failure. Pneumothorax is focus of recognition, cardiac tamponade, and others. It combines usually a non-invasive, that is the traditional we were talking about, which is measured on your monitors, as well as minimally invasive, and you get is a real-time data. So one point in time, a next point in time, maybe 10 minutes, 15 minutes later, or 5 minutes later, you have a value, and you know you can act upon it, because real-time data makes much more sense as compared to a one-time recording. Now, what are the tools that are available? Some of the tools we'll discuss, and we'll go over a few of them in brief, because many of these tools are going to be discussed. They were discussed at yesterday's meet or workshop. They're going to be discussed in the talks that are about to follow. There is arterial catheterization, which you measure blood pressure accurately, and there are issues with that, and we'll go over those. There is a central venous catheterization, which as of today's date only exists for administering vasopressors and various performing hemodialysis or ECMO. And its role in monitoring fluid therapy is kind of limited. You have echocardiography, focus, that you can do a lot of things. I hope you understand what VTI, volume, time integral, IVC, and B lines and vexes means. There is something which is more of a realm in the ICU rather than in the emergency department. But a lot of ICU equipment is now coming down. Now, what would the core monitoring parameters in India emergency department look like? I think this slide shows you all. What we would like to have is a blood pressure report of a non-invasive stuff, highlight pulses paradoxes. That is the systolic pressure drops by 10 with the respiration or more than 10. And it's indicative of cardiac tamponade if you have an asthma patient, acute severe asthma, restrictive pericarditis, restrictive cardiomyopathy as well. You have a pulsus alternance, that is one small and one large. You have one being little large on the patient or patient, and one which is a little weak, which usually implies an LV failure, a bad LV. You have a pulsus bifurians that talks about aortic regurgitation and stenosis, usually occurring together, more AR, less AS. And you have a parvus at tardus, because all of you, if you are level 3 students of MBS, you will recognize that these are classical patterns that are taught in that level. So you may see it particularly in patients of aortic stenosis. Point to remember is that arterial pressure gives you correctness as far as mean arterial pressure is to be measured. Systolic and diastolic pressures at times may become unreliable because of dampening effect. Okay, so you have to perform certain measures like a fast flush. So I hope there may be sessions of intra-arterial monitoring pressure. I can't go over the details for lack of time, but it is very important to make sure that your system is optimized to the center of the right atrium as well as the atmospheric pressure, both of them, and these have to be done time and time again. Now there is a equipment that has come in by the name of clear sight finger cuff pressure technique. This is used a totally non-invasive technique. It's based on a principle of Penaz, and that is that there is a cuff here on the top right you see, which is placed on the finger. There is a light emitting diode and a light sensing diode, and a constant pressure being made by a fusion method, so that the waveform that lies in the capillary is transmitted to that light sensing diode at the light that is passed, and that is what is displayed on the monitor down below. Now we have a whole lot of new scenarios. Continuous non-invasive blood pressure monitoring, unlike arterial, which is a little invasive. It measures all the stroke volume, cardiac output, systemic vascular resistance, stroke volume variation, and using the volume clamp method. There is a rapid deployment. You can set it up in less than 5 minutes, and it's ideal for an initial assessment for undifferentiated shock. But remember, it is invasive method of determination, like a PICO, which usually is an ICU scenario, and it's non-invasive. As I said, the applications, clinical shock recognition, titration of medication, how much vasopressors to give, how much to get down, so on and so forth, fluid responsiveness by stroke volume variation, and you have an hemodynamic trend. These trends can be read off, they can be stored in the central monitoring station, and you can go over them and compare it. What was it at R0, 0, 1, 2, 3, 4, and so on and so forth. So again, as I said, trends matter. Single time values may have some role, but not ideal. If you have a trend, it gives you much more information as compared to a single time. Now, let's talk about a little bit about focus. Some of you may already be knowing what I'm talking about. It also brings to a table a lot of findings or a lot of additional things that you can measure non-invasively. More importantly, that's a totally non-invasive method. There is no invasion to be done, and it's totally friendly at all. Also, it allows you to assess rapid cardiac output by assessing the LV outflow, VTI method. It's IVC assessment for volume, diameter, and collapsibility. LV function evaluation, visual ejection fraction or fractional shortening, and a rapid diagnosis of conditions like tamponade, PE, valvular, PE means pulmonary embolism, valvular dysfunction, pulmonary edema, and pneumothorax. Now, for those of you who've been through the focus yesterday would realize that what value it brings to the table. Equipment, though, may be expensive, but in the long term, the expense is borne out by the benefit that it gives. But there are limitations. There are limitations of operator dependence. You have to have a learning curve, a structured introduction to this particular technology having performed. And I will go on to say that until and unless you've done about 1,000 or so different scenarios, you could not call yourself competent enough to do so. So that's what it takes in the long run to acquire competency. Integration with data management and clinical are something clinical challenge. And again, all technology, whether it's finger clamp method, whether it's arterial pressure, or it is focus in the sources of extremes. Extremist means that a patient is almost very close to hemodynamic downfall. As we know that the downfall pathway for all patients in any sort of shock or any sort of sepsis, septic shock and so on is the same. The downhill course is the same. There the reliability is a little issue, is a bit of an issue. But before that, in emergency department, before deviation, lot of value. And just for mentioning the rush protocol, the race protocol, falls protocol, focus, fluid administration limited by lung sonography. Again, this for detection of lung extravascular fluid in the lung. And also, it gives information, a lot of good information about fluid therapy in collaboration with therapeutic monitoring. That is, you have a dynamic measures of fluid and administration like IV collapsibility or distensibility in mechanically ventilated patient, and performing a passive leg raising. I think you'll be hearing about this talk in the subsequent lecture. And therapeutic monitoring incorporates again this modality for vasopressor titrating, which usually would need an invasive BP arterial monitoring and measurement of serum lactate as well as urine output on hourly basis to track resuscitation that is going on. Now, what are the key parameters that emergency departments would like? Is it given by these four methods that I've discussed? I think the answer is a big yes. It gives you cardiac output index, everything you want to know. It gives you stroke volume, that is the cardiac function. It gives you systemic vascular resistance on which to act upon what vasopressor to use. It allows you continuous blood pressure monitoring, again to decide about various therapies. And dynamic indices of fluid responsiveness, like stroke volume variation, pulse pressure variation, and PLR. Remember, the first two, stroke volume and pulse pressure, are ideal in mechanically ventilated, optimized patients. That is with a normal tidal volume. PLR can be used in spontaneously breathing patients. And I think more will be in the next talk. And for assessment of shock, this is what a shock would look like. If you look at the parameters concerned by adding this technology, hypovolemic by low BP, high output, high heart rate, low urine output, collapsible IVC, and a pulse pressure variation if mechanically ventilated. Cardiogenic shock would look at low BP, pulmonary edema, reduced contractility, and if you perform echo in a patient who's in heart failure, it's a totally, whatever the crowd is, whatever the noise is, whatever your scope may be broken, you can immediately spot it out. This is a heart that is not contracting well, and this is a person who's in heart failure, and the shock is because of the pump action of the heart. For distributed shock, it would be, which is classical for septic shock, would be a low BP, high heart rate, elevated lactate, and normal or high cardiac output, depending on the stage of shock. And for obstructive, again, it is almost pathognomonic that you perform a proper study of the heart. You have a low BP and clear signs of pericardial effusion, tamponade on focus. If you know the early diastolic right ventricular collapse, as well as the PE signs of McConnell signs and a dilated RA and RV, in the proper setting that you're looking at, they are almost pathognomonic. Now there are some recommendation as far as this one. Like all patients do not need, as I said, only 15 to 20 patients would need to be monitored as far as ideally would be concerned in a rapid turnover emergency. You start with non-invasive, blood pressure, heart rate, SpO2 and AVPU scale. Any disturbances of this or instability, you go on to the minimally invasive techniques. And why? Because non-invasive BP is often inaccurate in obese people, in patient in extremis. It underreads the systolic and overreads the diastolic. CVP is again unreliable for fluid responsiveness. So CVP is now almost outdated only for performing various procedures. And focus usually requires training. So integrating monitoring with rapid interventions would be the ideal way to go about this particular job. And does it benefit the ED? The answer again, I hope I've convinced you all, is a big yes. It's a real-time continuous data for critical hemodynamic variables. There is less risk of infection and bleeding by using minimally invasive techniques and procedural complications, as well as diagnosing conditions like a pneumothorax, cardiac tamponade, pulmonary embolism in a fast-track manner. It would require a faster setup, very easy to set up. Intraarterial catheter, all it takes is inserting the catheter. For non-invasive finger cup, as I said, less than 5 minutes. And it supports goal-directed therapy. And I will show you some of the goal-directed parameters to watch out for. Fluid resuscitation and vasoactive drug management, like giving which vasopressors to give, which one to combine, when to take off one and add the second. However, there are limitations. It requires peripheral, at least a central venous pressure. The intravenous pressure you have to put because if you require vasopressors or others, it would be ideal to give them through a central line rather than from a peripheral line, which occasionally can be a little difficult to get. The reliability is again affected by certain limitations and by arrhythmias, obesity, edematous state like cirrhosis liver or the nephrotic syndrome. If you are a very edematous patient, a very obese patient, again setting up would be a problem. It requires calibration and some amount of operator skill. But ultrasound requires a little bit of structured training. That can affect accuracy. However, always remember it is not a substitute for clinical judgment. At times, as is happening in today's world, people are becoming more and more machine dependent. This is machine learning, it is not machine dependence. The machines are there as an adjunct to help you out. But overall clinical judgment has to be exercised by the individual who's doing the monitoring part. Okay, now having said that, I will like to introduce a certain other, this primarily came from my various cardiac surgery patients. It is the principle, works on the principle of electrical cardiometry, that is measuring electrical impedance of a small low volume AC current that is passed and measuring that and looking at aortic blood flow. It brings about quite a lot of non-invasiveness.
5 minutes.
Yeah, I'll finish. It brings about a lot of information at the bedside, like icon index of contractility, systolic time ratio, which is again a cardiac function, and fluid content. Now you have added another parameter of fluid content in addition to ultrasound focus. This is what the equipment is known by, marketed by Asutka Medical, which is a Japanese firm. And all that is brought in from blood flow, fluid status, cardiac function, vascular resistance, the oxygenation part as well by adding certain parameters to this machine. And it is a handheld machine. It requires 3 electrodes to be placed over the carotid artery and the base of the heart. The principle it works is that when aortic valve is open and blood is flowing, there is a increased electrical impedance, and when it is closed, the RBCs become in disarray and the electrical flow impedance is impeded. And this is a screenshot of what it looks like. Again, stroke volume, cardiac output, thoracic fluid content, icon contractility, systolic time ratio, and systemic vascular resistance. So you have this on one particular screen, and all is 3 electrodes placed. That's it. I'll leave you, I won't discuss too much of these. These are technology more in the ICU. You may have heard about flow track machine and the PICO machine. PICO machine would be ideal, but then it requires a very prolonged and a difficult setup and monitoring part as well. Now what I was talking about is a protocolized delivery. Emergency departments in patients who are unstable have to base them on some sort of protocol. And again, there's a session in the afternoon on this. What would a septic protocol look like? Shock. Mean arterial pressure 65. Lactate clearance greater than 20% or less than 2. Absolute value, CVP of 8 to 12, you could put substituted for focus here, IVC rather than that. And SCV of 2 more than 70%. That is a saturation of oxygen in the superior vena cava. Cardiogenic shock protocol would again look like a cardiac index which can be measured on focus. Sense of B-line or reduction in the number of B-lines, if there were 10 and it's down to 3 or 4, you know you're on the right track. And maintaining a urine output to prevent complications of heart failure, because cardiorenal syndrome usually accompanies people with underlying cardiac conditions. A hemorrhagic shock protocol would look like to allow for permissive hypotension, and not, I'd say just allow, not mandated. Balanced blood product administration and maintaining a temperature greater than 36 and a pH of more than 7.2. That is avoid the trauma triangle. Now clinical decision-making algorithms, initial assessment and a fluid responsiveness tree. Look for hypotension, signs of shock. You have the NEWS2 score, which is a European score or the UK score. It's greater than 5. Signs of hypoperfusion are there. You start immediately on arterial line and focus. Hemodynamically unstable, non-invasive would be the best method to go for. And for fluid responsiveness, which is the second basic question that one emergency physician have to answer is, it requires volume resuscitation by using your various methods, ultrasound focus studies or others. On mechanical ventilation, stroke volume variation, pulse pressure variation, assessment more than 12%, definitely. Give a fluid response bolus. Spontaneously breathing patient who requires volume resuscitation, perform a PLR and do a VTI response looking for bifocus or other cardiovascular necessity to reduce a patient who presented with severe mitral stenosis symptom, found to have a LA myxoma, and time to OT was almost reduced by about, let's say, about 6 hours or so. Patient was in the OT within the next 3 hours. There's initial investment issues. These are US figures, again, requires a lot of equipment. Layer site that I mentioned measures about 72 lakhs if you wanted with a CMC. But this would be realized through reduced ICU admission by about this figure and a shorter length of stay in the emergency department by a couple of days, which we've already talked about before. There is a per patient cost of saving, and disposable is offered by poor complications that will happen if you use non-invasive technique. This bar graph here represents what it would look like. A basic monitoring on your extreme left, non-invasive, invasive system, and long-term saving. So they will not give you initial investment in the time they were deployed in a year, but in the long term, they do stand to prove their value. Best quality evidence is strongest for focus out here, monitoring in terms of it's in a grade B recommendation, moderate quality of evidence. So final key takeaway points is that integrated multiple monitoring modalities provide you a comprehensive hemodynamic assessment. Non-invasive technologies can accurately guide fluid resuscitation and vasopressor therapies in most ED patients. Focus is again a game changer. Its advent and its recognition has made a lot of difference in form of hemodynamic assessment. Dynamic parameters often outperform the static measures in predicting various vasopressors as well as fluid responsiveness. And a protocol outcome is the one you need to aim for to reduce variability in critical care. And I leave you with this slide. Most of you can read this fast on. This is a handheld, on the top images of a handheld machine, ultrasound machine, which is like a mobile phone, no bigger than that, and can be carried from bedside. Again, in busy emergency departments, a quick assessment can be made by you. And all these are questions that need to be answered and thought for the future. Ladies and gentlemen, with that I come to the end of presentation, and thank you very much for your listening.
Thank you, sir. Next, we would like to welcome Dr. Pradeep Gopal, Consultant Intensive Care Physician, Manipal Hospital, Yashwantpur, Bangalore, on the topic Precision in Fluid Resuscitation.
So, good morning, friends. So, thanks WCEME for having me here for this scientific endeavor. So, the talk is a very interesting talk for all the trainees here. I see a lot of youngsters here on the principles of fluid resuscitation. So, can I have the slides? Hello. So what do we understand by fluid resuscitation or responsiveness? So please understand, when we give fluid, it is a drug, and one has to be very careful in following certain principles when you are giving a fluid. So when we say the patient is responsive to fluid, it means there is increase in the cardiac output when we give a bolus of fluid. So for all the audience present here, whenever we give fluid, it is imperative to think that we give fluid and patient responds with increase in the cardiac output. So when we are giving fluids, we have to be absolutely careful that we won't overflood the patients like this, or we'll keep them very dry. So the whole aspect of fluid resuscitation is to have a perfect balance of normovolemia, hypervolemia or hypovolemia. So this is what we are out to achieve in intensive care. And the studies, there are multiple studies which have shown that if you flood the patients either in sepsis, ARDS or intra-abdominal hypertension or AKI, if you give more fluid, it increases mortality and it increases the duration of mechanical ventilation. This is what studies have shown. So when we are giving fluids, we cannot be overzealous and we cannot be underzealous as well. So when we give a large volume in emergency or ICU, so our whole intent is to restore blood volume and restore blood pressure and MAP. So that's what we intend. And in the whole process, we intend to optimize the oxygen delivery. So, but we need to understand, in our zeal to do this, achieving blood volume and blood pressure and MAP and optimizing oxygen delivery, we should not over-resuscitate or under-resuscitate. So this is what the whole science is all about, and we have spent many years trying to understand what is the right amount of volume that we need to give. So, and in ICU, there is no role for maintenance fluid. We give fluid as a drug. So only when patient needs it, we have to give. Otherwise, we are not meant to give unnecessarily fluids. So for all the audience here, if you talk about fluid, we need to remember 4 Ds. So the right type of fluid, if you want to call it as a drug, and the type of fluid. So there's a whole lot of debate. What sort of fluids I would give in ICU or emergency? That is very important because certain fluids can be very harmful. And duration, how long would I give the fluid? And the dose, that's also terribly important. As I said, you overdo it, you will cause more harm. And there is a whole concept. You are okay to give lot of fluid, but at some point of time, to remove that fluid, which we call it as de-resuscitation in intensive care, and you need to fill the tank and dry the tank. That is the whole concept currently of fluid resuscitation. If you overload the patient and edematous, it causes higher mortality and worse outcomes. So if you just look into the fluid history, so it was started in 1830, where IV fluids roles was emphasized in cholera by this gentleman, William Brooke, where he saw the blood was thick in cholera patients because they lost all the fluid. And then Thomas Latta came out with his saline drip. And in 1880, the role of IV fluids in surgical patients by Sidney Ringer, now we call it as Ringer lactate, was made important and was emphasized. And in 1899, George Washington Creel put emphasis on warm Ringer lactate. And then the colloids came by W.C. Cannon, which was derived from gum arabica. And in 1924, Rudolf Matas used the IV drips to give fluid resuscitation. And in 1930, sodium lactate was discovered by Alexis Hartmann, which we call it as Hartmann fluid. So this is a sort of historical elements as to how the fluids have evolved over last 100 years, and many people have been part of this. So, and the whole perils of over-resuscitations came from this Vietnam War, where they used large volume fluid resuscitation to preserve renal functions, because many patients were found to be dying because of acute kidney injury due to rhabdomyolysis in Vietnam War. And the lungs got very wet. That's why they called this as Danang lung or wet lung. Now we call it as ARDS. If you overflood, there's a lot of inflammatory fluid in the lungs, we can call it as ARDS, or they die because of hypoxemic respiratory failure. So during at around this stage, the Shoemaker and colleagues, they sort of put up this emphasis on supranormal resuscitation to optimize cardiorespiratory functions as goal-directed fluid therapy. And now this has become obsolete for us, so we don't try to attain supranormal levels when we talk about fluid resuscitation. So now coming to the topic, so when we talk about precision in fluid, so we need to understand what is the right type of fluid that we need to give and what is the right dose. So that's what we call it as fluid stewardship or precision. So where we need to know what fluids we'll give, how long we'll give, what is the dose we give, and duration and de-resuscitation. So when we talk about fluid resuscitation, friends, as I said, it is with an intent that we improve the cardiac output, and the whole science boils down to this Starling's law, where you give a volume, you increase the cardiac preload. Sorry, I think that went away. So you increase the cardiac preload, you expect the rise in the stroke volume. So if you look into this figure, if someone has a decreased ventricular function, so even if you increase the preload, there is no concomitant rise in the stroke volume. That's why, friends, in intensive care or emergency, the initial echo evaluation or a focus is important to assess your cardiac function to determine if your heart is okay to respond with cardiac output to the amount of fluid. Because if you see the curve here, this is with the normal ventricular function, your fluid response or stroke volume response to the volume you give is much better as opposed to this down one, the orange curve, where you have a suboptimal response when you have cardiac function. That's why the whole effort is to assess cardiac function at the outset, either in ER or in ICU, to determine if the stroke volume response to the amount of fluid you give is going to be optimal. So when should we test fluid responsiveness? When patient comes to emergency hypotensive, no one is asking you to test for fluid responsiveness. When there's obvious hypovolemia, you start giving fluids, either in septic shock or hypovolemic. We don't ask you to check for fluid responsiveness. If they are hypovolemic, obvious hypovolemic signs are there clinically, you start giving fluids. But when would we give? After your initial resuscitation, patient continues to be unstable hemodynamically, your capillary refill is not happening, your urine output has come down, lactates is going up despite your initial resuscitation, and there is a mottling that has happened. That is when we need to check for tests for volume responsiveness that you heard from the previous speaker, and even then, only half of the fluid respond to to the fluid resuscitation, which means to say all the tests that we talk about to assess fluid responsiveness, even when you put it accurately, only half of them show response to the fluid. So that is the whole sort of a challenges that we have when we talk about fluid responsiveness in a patient. So this is a simple algorithm. When someone comes hemodynamically unstable, it is expected that we put arterial line, and as we all know, CVP line is only for administering sort of drugs and fluids. We no longer use it as a tool to guide or navigate fluid responsiveness. So you would put a CBC catheter or arterial and check for fluid response. But as a static variable, if CVP is high, then you wouldn't give fluid. So then if they are fluid responsive, then obviously hypovolemia likely, then you give the fluids, and then you give a fluid challenge. Suppose if your fluid responsiveness is absent, then at the outside you are expected to do an echocardiograph. Look if there are small chambers, and if you ascertain there is hypovolemia and cardiac function is good. If cardiac function is good, you can have room for more filling because you know there is going to be a good stroke volume response. If the cardiac function is depressed, you know there's not much room for giving you fluid because your stroke volume response to preload will not be great. And if there are large ventricles, poor contractile state, then you know there is a problem with dilatation or heart failure, then you have to be judicious and not administer allocates of fluids. And then you have to look for any other causes of shock like tamponade. So this is a simple algorithm which you can keep in mind. But echo evaluation is becoming imperative at the outset to determine whether your patient is going to respond well to the fluids that you would give. So now the question is, what is the optimal dose and type of fluid that you would give? Because there's significant variability in the global sort of a scenario as to the type and fluids that they give, and all this have an impact. Why are we so much sort of obsessed with the type and the dose of fluid? Because they all have influence on the outcome of the patient. So if you look into our surviving sepsis campaign, sepsis is a large cohort of patients, our suggestion is to give 30 ml per kg at the outset, and these are the indicators they suggest that you have to maintain MAP more than 65, urine output should be more than 0.5 ml, and mixed venous oxygen should be 65 to 70, and normalization of lactate. But we could dispute all this because all these are pertinent provided your cardiac function is normal. So we do fluid responsiveness based on static measure and dynamic measure. So dynamic measure is where we look into the heart-lung interaction, especially in patients who are mechanically ventilated. We look at the fluid responsiveness with lot of strategies. So, and studies have shown that CVP has a poor correlation with the blood volume, and there are studies which said the CVP has no correlation with the fluid responsiveness. As you see, area under curve is only 0.56, and CVP is abandoned in intensive care as a tool to guide our fluid resuscitation, because studies have shown there is poor correlation with the volume status. If CP is high, at least it tell you that don't give enough volume. And it is said that more than 50% of the patients in which fluid loading was clinically indicated are non-responders. Even though you do tests and determine the fluid responder, 50% may not necessarily respond with increase in the stroke volume the way you would want to. So there are certain dynamic measures we use in ICU after your initial fluid resuscitation, and this is based on increase in the intrathoracic pressure during inspiration and decrease in the intrathoracic pressure during expiration. So we look into these changes and we do various maneuvers, and one is a stroke volume variation. So we look into maximum stroke volume minus minimum divided by mean as a tools to measure. If it is more than 18%, then we know they are fluid responsiveness. Or the simplest thing for all the ER people or any doctor is to do IVC collapsibility index or IVC distensibility index as a tool. In a ventilated, we look at IVC distensibility. In spontaneously breathing, we look into IVC collapsibility index. If it is more than 40%, then we know they are fluid responsiveness. And passive leg rising test. Passive leg rising test is a simple test where you, in the olden days, if you remember, if someone was hypotensive, they used to lift the leg. So it is an auto resuscitation. You have around 250 ml of blood from the lower limbs and the lower part of the trunk, which gives a preload to the heart, and you look at increase in the stroke volume. That's all is the science. It is to send the blood from the lower limbs and the lower part of the trunk to the heart as an auto fluid bolus and look at the change in the cardiac output. And the other test, advanced test that we use, which was already elucidated in the previous speaker, is the esophageal Doppler and some of these tests that we do. So now we talk about the type of fluids. So when you look into the studies, so they are compared whether colloids are okay or crystalloids are okay. So if you look into the studies, there are multiple studies. There are at least some 30 to 40 studies which have compared the saline with the colloids or the crystalloids with colloids. So these are some of the landmark studies. As you see, most of the studies show if you give colloids, it increases the risk of acute kidney injury. And this was a study that came in 2012 where they compared hydroxyethyl starch with saline, and they showed that there is increased risk of death within 90 days. So which means many studies have shown that colloids are harmful. So for all the ER physicians, you have to be cautious in not administering colloids, at least from our scientific standpoint. And colloid usage increase the need of patient needing renal replacement therapy. And this was another study by Australia which came in 2012. They compared hydroxyethyl starch with Ringer's lactate, and they found no benefit with the starch. And there was an increased need for renal replacement therapy. This was the crystal trial that came in JAMA in 2013, where they compared colloids versus crystalloids in hypovolemic shock and septic shock, and 28-day mortality there was no. So all these studies basically said use of colloids did not confer any additional benefit. In fact, it increased the risk of death. Most studies in intensive care, we don't use albumin unless there are very specific conditions like burns or chronic liver disease. So the studies have very clearly shown, this was an Australian study which is a landmark study called SAFE study, where they compared 4% albumin and 0.9% saline, and they looked at 28-day outcome. It was similar, but use of albumin in traumatic brain injury caused more harm. So that is something we need to bear in mind. And this was another study where they used albumin and to improve organ function and reduce the cumulative positive fluid balance. Even there did not show any sort of a benefit. Then there was this Albios trial that came in 2014 where they maintained albumin more than 3 grams. Even there was no benefit with mortality. And of course the albumin group showed some little improvement in the hemodynamics. So this is a new trial that is ongoing called the ARIS trial, where they are maintaining albumin more than 3 grams per deciliter for 28 days, and they are looking at survival. The results are not out. So basically all this shows that unnecessarily giving albumin where there is no need not necessarily confers any additional benefit. And colloids, please don't give it because it increases the risk of acute kidney injury and it increases the risk of renal replacement therapy in this patient. So then there is a whole debate whether in crystalloids, so now the norm is we all have to use crystalloids. In crystalloids, whether we use saline or balanced solution. If you look at the composition of this fluid, as you see, saline has lot of chloride, 154 milliequivalents of chloride. And if you look into the balanced solution, the typical one we use is Ringer lactate or plasmalite. They have very less sort of a chloride, compared to the saline. And in addition to this, they have acetate and gluconate. So these are some advantages, and there are multiple studies to see whether should we use balanced solution, like plasmalite or Ringer lactate. So what does the study show? So this was the initial study where they showed if you don't use much chloride restrictive strategy, it reduces, because the increased chlorides in the saline causes acute kidney injury. And they showed by not using chloride-rich solutions like saline, it reduces the risk of AKI and reduces the risk of renal replacement therapy. Then 2015 we had this split trial that came from the Spanish group, which showed buffered crystalloids versus 0.9% saline. So buffered crystalloid did not reduce the risk of acute kidney injury, RRT, and hospital mortality. So all these studies initially showed that balanced solutions are more favorable than saline, but then the subsequent studies showed saline is as good as buffered solution. So this 2017 we got the SALT trial, which again compared saline with balanced solution, and balanced crystalloids did not have any difference with major acute kidney events at day 30. And then there was the SMART trial which compared saline and balanced crystalloids. Even major kidney events 30 was found to be lower in balance. So the whole argument is the chlorides in saline causes acute kidney injury. If you don't restrict this chloride, they would have better effect on the kidney. So that was the hypothesis for all these studies. Then the subsequent studies did show that it did not make. So then this basic trial came in 2021 from the Brazilian group, which again compared saline with balanced crystalloids, and they found there was no difference in 90-day mortality, no difference in acute kidney injury or RRT. In fact, they said in traumatic brain injury, use of albumin caused more harm. And even in this basics trial that came from Brazil showed if you use balanced solution in traumatic brain injury, it increased the mortality. So that is something we all need to bear in mind. As you said, there was a potential harm in TBI when you use balanced solution. So be careful. So saline is here to stay. So we are safe enough to use saline, but if you're using large volumes of saline, keep an eye on the chloride, because if chloride is creeping up, it can cause kidney injury. That is all you have to maintain. And then this plus trial came, which again compared saline and balanced solution plasma 145, and there was no reduction in 90-day mortality or acute kidney injury. So the bottom line is you can stick to saline, but keep an eye on the chloride, because the high chloride can cause worsening of the acute kidney injury. So that is the sort of a science we have at this point of time. And don't use colloids, albumin only in specific group of patients like burns or chronic liver disease, not as a routine to maintain albumin more than 3, does not cause any benefit in our intensive care patients. Now then there's the whole science. So you're given enough resuscitation, you're given the fluids based on your clinical acumen and all the advanced hemodynamic tools. Now there is a concept that you need to remove the excess fluid after you have given initial resuscitation, what we call it as de-resuscitation, because 10% of fluid accumulation extra in the body can cause harm. It is shown that our body is not geared up to have additional fluid within us in the compartments. That has shown to worsen the outcome. What are the deleterious effects of excess fluid? Excess fluid gets sequestrated in the brain, causing increase in ICP and circulation pressure, and the fluid sequestrated in all, causing compartment syndromes. They can cause hypoxemia, worsening of ARDS, they can cause myocardial dysfunction, they can cause conduction dysfunction. So all that extra fluid gets sequestrated in the tissues. And it is shown that fluid gets sequestrated in the liver also, causing liver dysfunction, and fluid gets sequestrated in the kidneys, causing worsening of the kidney function and renal. So this is the science we need to be aware. We can give extra fluid, but we need to remove it after some time. And even the fluid gets sequestrated in intestines, causing increase in the intra-abdominal pressure and abdominal compartment. So this pictorially shows that excess fluid in the patients can cause damage to organs due to sequestration of fluid into multiple organs, causing compartment syndrome. That's why we came with the concept of de-resuscitation, where this ROSE protocol came in, where you give initial resuscitation. No one is telling you not to give fluids, but once you give fluids, once patient is stabilized, once patient is optimized and stabilized, you have to start de-resuscitation. You have to remove that extra fluid. That is very important. And multiple studies are there. So this is a study which came in NEJM in 2023, where they have shown whether early restrictive or liberal fluid resuscitation. So look at the data. This is a large meta-analysis of 11 RCTs, 2051, where if you de-resuscitated, where you are given fluid and removed that excess fluid, ventilatory free days was increased. It means duration of ventilation was less, ICU length of stay also was less, as compared to the liberal group where you did not de-resuscitate. So the conclusion is in patients with sepsis and ARDS, conservative fluid resuscitation with de-resuscitation increases the ventilatory free days and reduces the ICU length of stay. And these are all the data from the retrospective large studies from sepsis, where the data, they showed in septic shock, positive fluid balance at day 4 increases the mortality, and the optimal survival is where positive fluid balance of 3 liters at around 12 hours. And this is another study from the SOAP study, where they showed positive fluid balance increases 60-day mortality, and early initiation to remove that fluid improves them. So what basically these studies are telling is, you give fluids, but at the end of day 3, you have to look into the cumulative fluid balance, and they cannot be hugely cumulatively positive. If they're positive, you have to diurese them and remove that extra fluid to improve the outcomes in these patients. And this is another study, large study, 730 ICUs in 84 countries, where they showed in survivors, day 3 fluid balance was negative. It means ER you can give how much ever fluid, but at day 3, try to see if they are net neutral balance or negative balance, and you are not allowed to keep them in cumulatively positive fluid balance, because the non-survivors at day 3 had a positive fluid balance. So very important to understand this concept, that you can give fluid resuscitation, but at day 3, try to maintain them at net neutral or negative balance, because the conclusions from this study was day 3 higher cumulative fluid balance independently increased the hazard risk of death. So that is something we need to be aware. So it's important to understand the concept of de-resuscitation. Positive fluid balance physiologically has many deleterious effects on lot of organ systems. And please understand the ROSE concept, where you resuscitate. In emergency, you resuscitate, you optimize the organ function, stabilize. After that, you have to evacuate or de-resuscitate the patient. E stands for evacuation. You have to evacuate the fluid. And 2006 to 22, there are around 10 studies which highlight harmful effects of positive fluid balance. And the targets that are reasonable is post-stabilization. Once patient is hemodynamically stabilized, try to achieve negative balance or net neutral balance by day 3 and attempt negative balance by day 7. Sustain negative balance more than 4 weeks also is not desirable. So at day 3, start looking at your cumulative fluid balance. So our journey of fluid resuscitation, when you look at the studies from last 30 years, reverse came with 168 ml per kg, and then the process trial in 2014 spoke about 130 ml per kg. Arise trial, which came from Australia, spoke about 109 ml per kg. Promise trial, all these studies were done in emergency. Promise, they spoke about 98 ml per kg as a resuscitation, and RIFS trial in 2019 speak about 47. So look at the journey, how we have become more conservative in our fluid resuscitation. That is the message, that you cannot be overzealous in your fluid resuscitation. And the refresh trial in 2018, 32 ml per kg. The classic trial in 2022 compared 1798 ml as a total fluid bolus, and Clover's trial, which is the latest, compared 1207 as a resuscitation cumulatively to very small volume resuscitation based our sort of hemodynamic tools and the principles that guide our fluid resuscitation. So summary, friends, so when we talk about fluids, it's a drug. So the amount of fluid we give, we have to be very judicious and cautious. And composition. So the composition is stick to saline. Saline is safe enough. At this point of time, don't use colloids. Albumin only in a very select group of, because all this, what I was talking to you, have a bearing on outcome. You give overzealously some other fluids, it can worsen the outcome. If you give starch or colloids, it worsens the outcome. So good to understand the fluid compartments in the body, because you give excess fluid, they all get sequestrated into multiple compartments, causing worsening organ dysfunction. That is what we need to realize. And different fluids are there in our armamentarium: crystalloids, colloids, albumin. Colloids have become obsolete. In fact, there is a recommendation against the use of colloids. So use crystalloids. Saline is good enough. When you are using excess saline, especially in DKA, keep an eye on chloride, because if chloride starts creeping up, then you can switch to balanced solution. Don't use balanced solution in traumatic brain injury. And current evidence do not favor the use of colloids because it worsens AKI. Albumin, no evidence to use as a fluid therapy in ICU except specific conditions. Chronic liver disease you can use. Chronic liver disease with sepsis you can use. Burns you can use. But apart from that, the indications are very less. Crystalloids, 0.9% saline. The cheapest sort of a crystalloids we have is saline, is more physiological. Balanced solution versus saline. At this point of time, as I'm talking to you, there is no difference. So you can use crystalloids, and balance and saline is what you can use. And post-stabilization, after emergency, they come to ICU, post-hemodynamic stabilization. Once hemodynamics are stabilized, achieve net neutral balance by day 3 and achieve negative balance by day 7. I think if you do that, you would improve the outcome. And CVP has no role in guiding our fluid resuscitation, and we use a lot of dynamic indices like passive leg rising, stroke volume.
Sorry for the
variation, pulse
interruption,
pressure
sir.
variation.
5 minutes more.
So that's about it, friends. Thank you very much. Request you all to submit your valuable work to Journal of Acute Care, for which I'm an editor. You can visit my website to rehear to all these lectures. Thank you. Thank you, Anand. We'll take questions at the end. Yeah, thank you.
Thank you, sir. We will invite Dr. Navneet Sharma to the dais. We would like to welcome Dr. Navneet Sharma for the felicitation.
We request the chairperson, Dr. Arunachalam Mainstream, sir, to felicitate the speaker.
We invite Dr. Tamil Al-Shoa to felicitate Dr. Pradeep Rangappa.
As we are in the process,
After the inaugural session. So we request the chairpersons to occupy the front chairs. The scientific session will proceed after the inaugural program.
Good morning, ladies and gentlemen, distinguished dignitaries, resource persons, and delegates from all over the globe, respected faculty members, dear students, and invited guests. On behalf of Aarupadai Veedu Medical College and Hospital Puducherry, a constituent college of Vinayaka Missions Research Foundation, deemed to be university, and the Association of Emergency Medicine Educators India, it gives me pleasure to welcome you all to the inaugural ceremony of the Emergency Medicine Educators 2025. We will be commencing the inauguration ceremony shortly as we are awaiting the arrival of our Honorable Chief Minister of the Union Territory of Puducherry, Shri N. Rangasamy. And I request you all to raise as a mark of respect to our Honorable Chief Minister of Union Territory of Puducherry, Thiru N. Rangasamy, as he enters the hall along with the other dignitaries. I request you all to raise. Ladies and gentlemen, please be seated.
I request everyone to be seated. Respected Honorable Chief Minister of Puducherry, Thiru N. Rangasamy, Honorable Chancellor Dr. A.S. Ganesan in absentia, Dr. Anuradha Ganesan, Vice President VMRF, Mr. J. Suresh Samvin, Member Board of Management VMRF, Dr. R. Mani, Dean AVMCH, Dr. Arunachalam Einstein, Organizing Chairman, International WCEME 25, Dr. Kabilan Dharmarajan, Organizing Co-Chairman, International Level, Professor Ashima Sharma, Organizing Co-Chairman, National Level, WCME, Dr. V. A. Rajan, Organizing Chairman, National Level, WCME, Dr. Damodaran, MS, Vice Deans, Directors, Deputy MS, Heads of Institutes, HODs, Faculties, Learned Resource Persons, esteemed delegates, national and international level, students and invited guests, with the blessings of God Almighty, Founder Chancellor Dr. Shanmuga Sundaram, and On behalf of Aarupadai Veedu Medical College and Hospital, Puducherry, a constituent college of Vinayaka Missions Research Foundation, deemed to be university, and the Association of Emergency Medicine Educators, India. It gives me immense pleasure to welcome you all to the inaugural ceremony of World Congress of Emergency Medicine Educators, WCEME 2025. I am Dr. S. Deepa, Professor and HOD OBG AVMC.
And I am Dr. Manju, Professor and Head Department of Biochemistry, and will be hosting the inaugural ceremony of WCEME 25 today. Department of Emergency Medicine, it stands at the front line of healthcare, providing immediate life-saving interventions to patients in critical need. It plays a pivotal role in bridging acute care with definitive treatment, ensuring timely diagnosis, stabilization, and referral across all the specialities. As the backbone of the patient-centered care, it exemplifies the integration of speed, precision, and compassion in modern medicine. The theme for this conference is Learning by Doing, Advancing Hands-on Training in Emergency Medicine, a theme that resonates with the very essence of medical education and practice. The theme emphasizes the power of experiential learning. It highlights that true mastery in emergency care comes not only from knowledge, but from practice, skill building, and real-time application that prepares the physicians to save lives when every second counts. So, with this small introduction, before we officially, we welcome our Honorable Vice President VMRF, Dr. Anuradha Ganesan ma'am, to this today's inaugural ceremony of WCEME 2025. Welcome ma'am. So before we officially start the program, we would like to capture this historic moment and the spirit of today in a group photograph. May I kindly request our Honorable Chief Minister, dignitaries, along with the organizing team to please join together for the photo session. Photographs, they are not just pictures, they are timeless memories, a way of holding on to the moments we never wish to forget. Let this photograph remind us of the commitment and the collaboration that brought us all here today at WCEME 25. I request the photographer to come forward and capture this wonderful moment. Ladies and gentlemen, as we prepare to begin this inaugural ceremony, it's my privilege to invite our esteemed dignitaries to kindly occupy their dais. May I take the honor to request our Honorable Chief Minister of Puducherry, Shri N. Rangasamy, Dr. Anuradha Ganesan, Honorable Vice President, VMRF, Mr. J. Suresh Samuel, Member Board of Management, VMRF, Dr. R. Mani, Dean, AVMCH, Dr. Arunachalam Einstein, Organizing Chairman, International Level, WCEME 25, Dr. Kabilan Dharmarajan, Organizing Co-Chairman, International, Professor Ashima Sharma, Organizing Co-Chairman, WCEME 25 Level, and Dr. V. Edil, Organizing Chairperson, National Level for WCEME 25.
Thank you, sirs and ma'ams. To begin this auspicious occasion, may I request everyone to raise for the Puducherry Tamil Thai Valtu, presented by our interns, Ms. Shri Lakshmi Nair and Ms. Mahima.
செம்மையை செய்பவள் நீயே, மாண்புகள் நீயே, என் தமிழ் தாயே, வீழ்வாரை வீழாது காப்பவள் நீயே, வீரனின் வீரமும் வெற்றியும் குனிவேனோ சூழ்ந்தின்பம் நல்கிடும் பைந்தமிழன்னாய் தோன்றுடல் நீயுயிர் நான் மறப்பேனோ செந்தமிழே உயிரே நருந்தேனே செயலினை மூச்சினை உனை கணித்தேனே நெய்நாயனில் நைந்து போகும் என் வாழ்வு நல்லினை உனக்கெனில் எனக்கும் தாயே முந்திய நாளினில் அறிவுமில்லாது மொய்தன மனிதராம் புது புனல் மீது செந்தாமரை காடு பூத்தது போலே செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி.
Please be seated. Thank you, Sri Lakshmi and Mahima. The symbolic lighting of Kuthuvilakku, which signifies the dispelling of darkness and spreading of wisdom and knowledge. Now, I invite our Honorable Chief Minister of Puducherry, Shri Rangasamy, Dr. Anuradha Ganesan, Honorable Vice President VMRF, Mr. J. Hon'ble, Member Board of Management, Dr. R. Mani, Dean, along with other esteemed dignitaries to come forward for the lighting of the lamp.
To extend a warm welcome and set the tone for today's program, may I now invite Professor Ashima Sharma, Organizing Co-Chairman, National Level for WCEME 25, to deliver the welcome address.
Very good morning to everyone. Respected Honorable Chief Minister of Puducherry, Sir, and Rangasamy, Sir, and Dr. Anuradha Ganesan, Vice President, VMRF, Mr. Suresh Samuel, Sir, Member, Board of Management, Dr. R. Mani, Dean, Sir, Dr. K. Damodaran, Medical Superintendent, Sir, Dr. P.K. Sudhir, Vice Chancellor of VMRF, all the university officials from Salem and Chennai branch, and all other head of institutions, members of leadership team of Vinayaka Mission Puducherry campus, and Mr. Prasad, Sir, who is the observer from Tamil Nadu Medical Council, esteemed dignitaries on the dais, in the audience, distinguished care and education in this region. We are truly grateful for your support in strengthening the emergency care system, which signifies a pillar of public health and safety. This conference brings together experts, educators, and practitioners in the field of emergency medicine, trauma care, toxicology, and life-saving emergency interventions, aiming to share their knowledge, train hands, and ultimately save lives. In a field where every second matters, this gathering is a step towards better preparedness, sharper skills, and stronger systems. We also extend a heartfelt welcome to all the respected dignitaries, national and international colleagues, and enthusiastic delegates who have joined us today. Let us together make this event impactful, meaningful to our profession, and more important, to the lives we touch every day. Nandri, thank you.
Thank you, ma'am, for your warm words. It's now time to felicitate our distinguished dignitaries who have graced this occasion. I request Honorable Vice President VMRF, Dr. Anuradha Ganesan, and Mr. Suresh Sambel, Member Board of Management, to felicitate our Honorable Chief Minister for Union Territory of Puducherry, Thiru N. Rangasamy. Thank you, Madam and Sir. Now I request our respected Dean, Dr. R. Mani, to felicitate Dr. Anuradha Ganesan, our Honorable Vice President, VMRF. I humbly request our respected Dean, Dr. R. Mani, to felicitate Mr. Suresh Sambel, Member Board of Management. I request our Dean to felicitate Dr. Arunachalam Einstein, Clinical Assistant Professor of Emergency Medicine from USA and Organizing Chairman International. I request Dean Sir to felicitate Dr. Medicine, Boston, USA and Organizing Co-Chairman, International Level. Thank you, sir. Now I invite Dr. V. Rajan, Organizing Chairman, National, WCEME, Professor and Head, Department of Anesthesia, to felicitate our respected Professor Ashish Sharma, Senior Professor and Head of Department of Emergency Medicine, Nizam's Institute of Medical Sciences, and she is the Organizing Co-Chairman, National Level. Now I invite Dr. L. Rajan to felicitate our respected Dean, Professor Dr. R. Mani. Thank you, sirs.
It's a moment of great pride for all of us to welcome our Honorable Chief Minister of the Union Territory of Puducherry, Thiru N. Rangasamy, sir. We are honored by your presence here, sir. We now invite you to ring the gong and inaugurate the WCEME 25 and deliver the inaugural address. I please invite you. Please. Yes.
அனைவருக்கும் வணக்கம். அறுவடை வீடு மருத்துவக் கல்லூரியில் நடைபெறுகின்ற இந்த வேர்ல்டு காங்கிரஸ் ஆஃப் எமர்ஜென்சி மெடிசன் எஜுகேட்டர்ஸ் ஒரு நல்ல மாநாடு. இந்த மாநாட்டில் கலந்து கொண்டு அவசர கால மருத்துவ சிகிச்சை, இந்த மாநாட்டின் ஒரு முக்கிய நோக்கம் learning by doing, advancing and on training in emergency medicine. ஒரு நல்ல டீம், இந்த மாநாட்டில் ஒரு நல்ல டீம். இதில் கலந்து கொண்டு இந்த மாநாட்டில் தொடங்கியதும் எனக்கு மிகுந்த மகிழ்ச்சி. நிறைய சிறந்த மருத்துவ நிபுணர்கள் இங்கே வந்திருக்கிறார்கள், பேராசிரியர்கள் வந்திருக்கிறார்கள், வெளிநாட்டை சார்ந்த சிறந்த மருத்துவ நிபுணர்கள் இங்கே கூடியிருக்கிறார்கள். இது ஒரு பெரிய மகிழ்ச்சி. நம்முடைய பிள்ளைகளுக்கு ஒரு நல்ல வாய்ப்பு, நம்முடைய மாணவர்களுக்கு ஒரு நல்ல வாய்ப்பு. மருத்துவ துறையில் பொழுது மருத்துவக் கல்வி படித்துக் கொண்டிருக்கின்ற மாணவர்களுக்கு ஒரு நல்ல வாய்ப்பு. படிக்கிறது ஒரு பக்கம், ஆனால் அது நடைமுறையில் அவர்கள் சிறந்த மருத்துவ நிபுணரோடு இணைந்து பணியாற்றும் பொழுது அவர் கற்றுக்கொள்வது இன்னொரு விதம். படிக்கிறது கூட இருந்து கற்றுக்கிறது ஒரு தெரிந்து கொள்வது என்பது நோயாளிகளுக்கு சிறந்த பயனை கொடுக்கக்கூடிய ஒன்றாக இருக்கும். சிகிச்சை செய்கின்ற காலங்கள் அந்த நேரத்தில் இப்போ மருத்துவ உலகம் எந்த அளவுக்கு முன்னேறி இருக்கிறது அப்படின்னு நம்ம பார்க்கலாம். மருத்துவ சிகிச்சை முறை அது வந்திருக்கின்ற தொழில்நுட்ப மாற்றங்கள், புதிய தொழில்நுட்பங்கள், இவை எந்த அளவுக்கு உயிரை காக்கக்கூடிய ஒரு நிலையில் இருக்கிறது என்று நம்ம எண்ணி பார்க்கக்கூடிய நிலையில் இருக்கு. அந்த அளவு பெரிய ஒரு புதிய தொழில்நுட்பம் வளர்ச்சி. முன்பெல்லாம் இந்த நோய் வந்தால் படிப்பாங்களா அப்படின்னு ஒரு சந்தேகம் இருக்கும், ஐயம் இருக்கும், எல்லாம் இருக்கும். ஆனால் இன்றைக்கி அதையும் தாண்டி பிழைக்க வைக்க முடியும் அப்படின்ற ஒரு நிலையில் மருத்துவ அந்த துறை வளர்ந்திருப்பதை நம்மளால் பார்க்க முடிகின்றது. முடியும் அப்படின்னு நிலை அதற்கு காரணம் சிறந்த மருத்துவர்கள், சிறந்த மருத்துவ தொழில்நுட்பங்கள், கல்வி முறை, இவையெல்லாம் மனிதனுடைய உயிரை காக்கக்கூடிய நிலையில் வளர்ந்திருக்கிறது என்று எண்ணும் பொழுது அது எல்லோரும் வரவேற்கக்கூடிய ஒன்று, மகிழ்ச்சி அடையக்கூடிய ஒன்று. புதிய தொழில்நுட்பத்தை அறிந்து கொள்வது. ஒன்று பார்த்தீங்கன்னா இதே தினம்னு நினைக்கிறேன், இன்னைக்கு இதே தினம்னு நினைக்கிறேன். இதே தினத்தில் நீங்கள் பார்த்தா நம்முடைய இதயத்தை ஒரு பலமாக நல்லா வச்சிருக்க வேண்டிய அவசியமான ஒன்று. இதய நோய் அப்படின்னு சொல்லும்போது இப்போ ஹார்ட் அட்டாக் வருது அப்படின்னு சொல்லுவாங்க. இப்போலாம் பார்த்தீங்கன்னா ஒரு ஹார்ட் அட்டாக் அப்படின்னு சொன்னால் படிப்பாங்களோ இருப்பாங்களோ இருக்க மாட்டாங்களோ உடனே என்ன அப்படின்ற மாதிரி ஒரு எண்ணம் வரும். ஆனால் இன்றைக்கு அவர்களெல்லாம் நம்ம பாதுகாக்க முடியும். உடனே ஒரு சிகிச்சை அளிக்கும்போது, ஒரு உடனடி அவசர சிகிச்சை அளிக்கும்போது அவர்கள் பிழைக்க வைக்க முடியும், உயிர் காக்க முடியும் என்ற ஒரு நிலை இருப்பதை தான் பார்க்கலாம். அதே சமயத்தில் இன்னொன்றையும் போடலாம். மருத்துவ சிகிச்சை முறையில் வளர்ந்து வரும்போது, தொழில்நுட்பம் வளர்ந்து வரும்போது அதற்கான செலவுகள், அதுக்கு செலவிடுகின்ற தொகை என்பது சற்று கூடுதல் என்று கூட சொல்லலாம். இப்போ நம்ம பார்க்கலாம், உயிர் காக்கணும் அப்படின்னு நினைக்கும் பொழுது நம்ம உயிர் பழைக்கணும், நம்ம கூட இருந்தபடி எப்படி இருக்கிறோம் அப்படின்னு அவருக்கு நம்ம நல்ல சிகிச்சை கொடுக்கணும் அப்படின்னு நினைக்கும் பொழுது ஒரு சிறந்த மருத்துவமனைக்கு நம்ம அழைச்சிட்டு போகணும். ஆனால் நிச்சயமாக அவருடைய உயிர் காக்கப்படுகின்றது, அது எந்த ஒரு ஐயம் இல்லை. ஆனால் கொஞ்சம் கூடுதலான செலவு, சிறந்த மருத்துவ நிலையில் சிறப்பு மருத்துவ நிலையால் சிறந்த ஒரு மருத்துவமனையில் சேர்க்கும் பொழுது கொஞ்சம் செலவு அப்படின் போது கூடுதலாக இருப்பதை நாம் காண முடியுது. அதுக்காக மக்கள் அதிகமாக செலவிட காத்திருக்கிற அவசரத்தை செய்யக்கூடிய நிலையில் அவர்கள் இருக்கின்றார்கள் என்பதை நம்ம பார்க்க முடியும். அரசை பொறுத்த வரைக்கும் அதுக்கு தேவையான உதவியை செய்ய வேண்டும், நம்முடைய மக்களுக்கு தேவையான உதவி செய்து கொடுக்க வேண்டும் என்று மிகுந்த கவனமாக இருந்து கொண்டிருக்கிறார். எந்தெந்த வகையில் நல்ல மருத்துவ வசதி செய்து கொடுக்க வேண்டும், நல்ல மருத்துவ வசதி மக்களுக்கு கிடைக்க வேண்டும், சிறப்பு மருத்துவ வசதி அவர்களுக்கு எவ்வாறு கிடைக்கின்ற வாய்ப்பை நாம் உருவாக்கி கொடுக்க வேண்டும் என்றெல்லாம் அரசானது மிகுந்த கவனம் செஞ்சு வருகிறது, ஆர்வம் வைக்கிறது. அதுக்கான திட்டமிட்டு அதுக்கான நிதியை ஒதுக்கி கொடுத்து கொண்டிருக்கிறது. பொதுவாக மருத்துவ என்ற நிலையில் அந்த துறைக்காக அதிக நிதியை ஒதுக்கி கொடுத்து நாம் நம்முடைய மக்களுக்கு சிறந்த மருத்துவ சேவை கிடைக்க செய்து கொண்டிருக்கின்றோம். அது எந்தவித செய்யும். புதுச்சேரி மாநிலத்தை பொறுத்த வரைக்கும் நல்லா தெரியும், ஒரு கல்வி அப்படின்னு சொல்லும்பொழுது எல்லோருக்கும் கல்வி, ஏழை நடுத்தர குடும்பம் அப்படி பார்க்கும்போது எல்லோருக்கும் அந்த கல்வி கிடைக்க வேண்டும், எல்லோரும் கல்வி உயர்கல்வி கிடைக்க வேண்டும் என்பதை மிகுந்த ஆர்வம் பெற்று நீங்கள் பார்க்கலாம். புதுச்சேரி பொறுத்தவரை நம்முடைய புதுச்சேரி மாநிலம் பார்க்கும்போது உயர்கல்வி கொடுப்பது 2ஆம் இடத்தில் நம்ம இருக்கின்றோம். இந்தியாவிலேயே 2வது ஒரு சின்ன மாநிலம், நம்ம சிறிய இடம், 2ஆம் இடத்தில் இருக்கின்ற உயர்கல்வி, அதாவது பட்டப்படிப்பு கல்லூரிகளில் படிக்கின்ற வாய்ப்பு நம்முடைய பிள்ளைகளுக்கு 12ஆம் பள்ளி கல்வி முடித்தவுடன் அவர்கள் கல்லூரி சேர்வதற்கு எல்லோருக்கும் வாய்ப்பு ஒரு நிலையில் அரசானது கல்லூரியை கொண்டு வருகிறது. இங்கே தனியார் கல்லூரிகளுக்கு அனுமதி அளித்து வருகிறது. பொறியியல் கல்லூரி, மருத்துவக் கல்லூரி, ஒரு சின்ன எத்தனை மருத்துவக் கல்லூரி பார்க்கலாம், எத்தனை மாணவர்கள் வெளியே வந்து கொண்டிருக்கிறாங்க. நம்ம புதுச்சேரி இருக்குது. புதுச்சேரியை சார்ந்த மாணவர்கள் ஏறக்குறைய நம்முடைய அரசு மூலமாக அனுப்பப்படுகின்ற மாணவர்கள் ஒரு 450 மாணவர்கள் எடுத்துக்கொண்டு இங்கே வந்து மற்ற தனியாக வந்து சேர்ந்து படிக்கின்ற மாணவர்கள் எவ்வளோ பேர் சொல்லுவாங்க எழுதுறாங்க. அவ்வளவு மருத்துவர்கள் புதுச்சேரிக்கு படித்து வெளியே வந்து கொண்டிருக்கிறார்கள். இவர்கள் மூலமாக நமக்கு நல்ல மருத்துவ வசதியை கிடைத்துக் கொண்டே. நான் அடிக்கடி சொல்றது, எல்லா மருத்துவக் கல்லூரி சார்ந்த நம்முடைய தலைவர்களுக்கு அடிக்கடி சொல்வது, ஒரு நல்ல, அதாவது ஒரு நல்ல தரமான மருத்துவ படிப்பு என்பதை நீங்கள் கொடுக்க வேண்டும், அதை அதிக கவனம் செலுத்த வேண்டும். இருக்கணும் எல்லாம் புதிய தொழில்நுட்பங்கள் என்னென்ன கொண்டு வர முடியுமோ அந்த தொழில்நுட்ப வளர்ச்சியை இங்கே கொண்டு வர வேண்டும். அந்த பள்ளிகள் பிள்ளைகள் தெரிந்து கொள்ள ஒரு வாய்ப்பை உருவாக்கி கொடுக்க வேண்டும் அடிக்கடி சொல்லுவோம். அது மாதிரி கல்லூரிகள் இப்போது நல்ல மருத்துவ கல்லூரிகள் புதிய தொழில்நுட்பத்தில் என்னென்ன வசதிகள் இருக்கின்றோ அதை நீங்கள் கொண்டு வருகிறார்கள். அது இந்த கல்லூரி நமக்கு அறுவடை மருத்துவக் கல்லூரி ஒன்று. நான் அடிக்கடி விசாரிப்பேன், எப்படி கல்லூரி வந்து சரியான பிள்ளைகள்லாம் பார்ப்போம், அடிக்கடி பார்ப்போம், சொல்லுவேன். இப்போ நல்லா ரொம்ப நல்லா வந்துட்டு சொல்லுவாங்க. அதில் ஒன்று தான் இப்போ இந்த கான்ஃபரன்ஸ் இது மாதிரி ஒரு மாநாடு நடத்துவது. இப்போ இந்த துறை எமர்ஜென்சி மெடிசன் அப்படின்னு சொல்லும் பொழுது, இப்போ புதுசாக அவசர கால மருத்துவ சிகிச்சை உயிரை காக்கக்கூடியது எந்த அளவிற்கு ஒரு புதிய தொழில்நுட்பத்தின் மூலமாக உயிரை காக்க முடியும் என்பதில் ஒரு பிரிவு எமர்ஜென்சி மெடிசன் கொண்டு வந்திருக்காங்க. இப்போ பிள்ளைகளும் அதில் ஆர்வம் காட்டி அந்த பிரிவு எடுத்து படித்து வருகின்றார்கள். அந்த தொழில்நுட்ப வளர்ச்சிக்காக ஏற்றவாறு அதற்கு மருத்துவ நிலையில் அதற்குரிய டெக்னீஷியன் சொல்லக்கூடிய நிலையில் அந்த மாதிரி ஒரு கோர்ஸ் கொண்டு வந்து ஒவ்வொரு இடத்தையும் கொண்டு வந்து. அப்போ ஒரு அவசர கால சிகிச்சை அது எப்படி இருந்தால் நம்ம அடிபட்டவர்களுக்கு உடனடியாக பாதுகாப்பு உயிர் பிழைக்க வைக்க முடியும். அது வேற ஒரு நோய், அந்த நோய்க்கு ஏற்றவாறு எவ்வாறு ஒரு அவசர நிலையில் சிகிச்சை கொடுக்க முடியும். இப்போ சண்டை நடக்குது, போர் என்ற அடிப்படை பார்க்கும்போது அந்த அடிப்படை பொழுது அவருக்கு எப்படிப்பட்ட ஒரு நிலையில் உடனடியாக சிகிச்சை கொடுத்து அவங்களுக்கு பலனளிக்கும் அப்படின்ற மாதிரிலாம் பார்க்கும்போது இந்த புதிய தொழில்நுட்பங்கள் கொஞ்சம் நாள் சொல்லிட்டு இருந்தாங்க. அவங்க வெளியிலேருந்து வந்த நம்ம மருத்துவ நிபுணர் சொல்லும்போது நிறைய வித்தியாசம் இருக்குது. நம்ம பிள்ளைங்களும் தெரிந்து கொள்ள வேண்டிய மிக அவசியமான ஒன்று. நிறைய செய்திகளுக்கு பரிமாற்றம் வருகிற ஒரு வாய்ப்பு இருக்கின்றது. அவங்க சொல்கிறதும் ஒரு வித்தியாசமாக இருக்குது. ஏன்னா ஒவ்வொன்றிலும் புதிய தொழில்நுட்பம் வளர்ந்து இருக்குது. ஒவ்வொரு நிலையிலும் நம்முடைய பேராசிரியர்கள் மருத்துவ நிபுணர்கள் இவர்களெல்லாம் அதாவது அனுபவம் என்பது மிக முக்கியமான ஒன்று. அந்த அவருடைய அனுபவத்தின் மூலமாக இந்த படிக்கின்ற பிள்ளைகளுக்கு, இந்த மாணவர்களுக்கு ஒரு நல்ல வாய்ப்பு, சிகிச்சை முறையை எவ்வாறு அறிந்து கொள்ள முடியும், அதன் மூலமாக நாம் நோயாளிகளுக்கு உதவிகள் செய்ய முடியும் என்று தெரிந்து கொள்வதற்கு ஒரு நல்ல வாய்ப்பு. ஏன்னா ஒவ்வொன்றையும் தெரிந்து கொள்ளும் பொழுது தான் ஒரு சிறந்த மருத்துவம் வரணும் அப்படின்னு சொன்னால் நிறைய நோயாளிகளை பார்த்தா தான் ஒரு சிறந்த மருத்துவம் முடியும். அதுக்கு வாய்ப்பினை உருவாக்கி கொடுக்கிறது நம்முடைய கல்லூரியே கடமை. இந்த கல்லூரி மிக சிறந்த முறையில் இப்பொழுது செய்து கொண்டிருக்கிறது. அந்த மாணவர்கள் பெரிதும் பயன்பெறுகின்ற நிலையில் இது போன்ற மாநாடுகள் அமைவது மிக முக்கியமான ஒன்று. மருத்துவத்துறை எத்தனையோ ஒரு பெரிய வளர்ச்சி. ஒரு புதிய நிலையில் அரசானது ஒரு நிறைய நாங்கள் அரசு மருத்துவமனையில் கூட நோயாளிகளுக்கு இப்போ அறுவை சிகிச்சை செய்ய வேண்டும் அப்படின்னு சொன்னால் அதுக்கு மருத்துவர் நமக்கு அரசில் கிடைக்கிறது ஒரு சிரமம். இப்பொழுது மற்ற பெரிய மருத்துவமனையில் வந்து சிறந்த மருத்துவர்கள் ஒப்பந்தம் செய்து கொண்டு இப்பொழுது அந்த இதய அறுவை சிகிச்சை பூச்சி நாம் அரசு மருத்துவம் செய்து கொண்டு இருக்கின்றோம். ஏற்கனவே சுமார் ஒரு 600 நோயாளிகள் அந்த அறுவை சிகிச்சை நல்ல நிலையில் இருக்கிறார்கள். குறைந்த எந்த செலவும் இல்லாமல் அந்த இதய அறுவை சிகிச்சை செய்து கொண்டு இருக்கின்றார்கள். இன்னொரு பெரிய வளர்ச்சி. எல்லா துறைகளும் எல்லா நோய்க்கும் சிகிச்சை அளிக்க வேண்டும் என்பது அரசுடைய ஒரு எண்ணம். இங்கே புதுச்சேரி பொறுத்தவரை நாங்கள் எதிர்பார்ப்பது சிறந்த மருத்துவ வசதி மக்களுக்கு கிடைக்க வேண்டும். சிறந்த மருத்துவர் இங்கே வந்து சிகிச்சை அளித்து அவர்களுக்கு உயிர்ப்பிடிக்கின்றதை அவர் உதவிகள் செய்ய வேண்டும் என்பது என்னுடைய எண்ணம். அதுக்கு ஏற்றவாறு அரசும் திட்டமிட்டு நிதி அதிகமாக ஒதுக்கி துறைக்கு செலவிட்டு வருகின்றது. நம்முடைய புதுச்சேரி குறிப்பிட்ட ஒரு மருத்துவ கல்லூரி இருக்கிறது. புதுச்சேரி சார்ந்த நம்முடைய மக்களுக்கும் சரி பிள்ளைகளுக்கும் சரி ஒரு நல்ல வாய்ப்பினை உருவாக்கக்கூடிய இந்த மருத்துவ வசதி பெரும் நிலையில் இருக்கின்றது என்று எண்ணி பார்க்கும்பொழுது மிகவும் மகிழ்ச்சியாக இருக்கிறது. இந்த மாநாடு வெற்றி அடைகின்றது. வாழ்த்துக்கள். நம்முடைய சிறப்பு மருத்துவ நிபுணருடைய அறிவுரை கேட்டு நம்முடைய பிள்ளைகள் படிப்பில் அதிக கவனம் செலுத்த வேண்டும், நன்றாக தெரிந்து கொள்ள வேண்டும். தெரிந்து கொள்கின்ற நிலையில் நோயாளிகளிடம் பழகி நோயாளிகள் சிகிச்சை அளித்து சிறந்த மருத்துவராக இங்கு படிக்கின்ற மாணவர்களும் சிறந்த மருத்துவர்களாக வர வேண்டும் என்று அவர்களை வாழ்த்தி மாநாடு வெற்றி பெற வாய்ப்பு விடுகிறேன். நன்றி.
Thank you very much, sir, for gracing this occasion in spite of your busy schedules, sparing some time and sharing your ideas with all our delegates. Sir has highlighted on the need for personal care that we have to give for our health, as well as he has given an idea about the medical educational systems prevailing in Puducherry, and he has also shared his dream of making Puducherry a fully healthy Puducherry, and with emphasizing on the role of experience in, let it be a medical or a paramedical professional curriculum. Thank you very much, sir, for sharing all these things with us. Thank you. So now we would sir, can we So now, ladies and gentlemen, we now come to one of the most significant and proud moments of this program. It's our privilege to recognize and honor two outstanding Tamil medical professionals from the United States of America who have made remarkable contributions in the field of medicine, research, education, and service to humanity. These distinguished doctors of Tamil origin, they have not only excelled in their professional careers abroad, but have also carried the name of Tamil Nadu across the globe with pride. Their dedication to advancing medical science and their humanitarian service continue to inspire younger generations of doctors and students here in our homeland. So, first, to bestow this honor upon them, may I, with utmost respect, invite our Honorable Chief Minister of Puducherry, Thiru N. Rangasamy sir, to kindly come forward and honor them. First, I call upon Dr. Arunachalam Einstein, Clinical Assistant Professor of Emergency Medicine, Washington State University. He has served at the Michelle County Hospital, Providence Regional Medical Center, and Family Healthcare Corporation, and holds a Washington State medical license. He has held various academic roles and received multiple honors, such as Best House Officer of the Month in 1994, Primary Care Resident of the Year 1997. And he is from the Nassau County Medical Center. Thank you, sir. Now I call upon Dr. Kabilan Dharmarajan, Associate Professor of Medicine from TUFTS School of Medicine, Boston, USA. He is a distinguished professional in the field of internal medicine. He is the Chair of the Internal Medicine at the Lowell General Hospital. He is the organizing chairperson too for WCEME 25. He is the President of the American Tamil Medical Association here. There. Thank you, sir, for doing the honor. We were deeply honored to have commitments that require his immediate attention. Our Chief Minister must depart earlier than planned. We understand and respect the demands of his position and grateful for the time he has managed to give us. Thank you, sir.
So kindly be seated because the Fellowship Awards ceremony of Association of Emergency Medicine Educators is to start. Kindly be seated here.
I request everybody to please remain in the hall. Please don't leave the hall. We humbly request you to please remain seated. We'll be continuing the inaugural ceremony. Please give us a second. We are waiting for our Dean to come back and we'll continue with the inaugural ceremony. To give us an overview of the vision and purpose of this Congress, I now invite Dr. R. Mani, respected Dean, AVMCH, to share his insights.
Good morning to all. The World Congress of Emergency Medicine Educators, WCEME 2025, marks a defining moment in the academic journey of Puducherry. Organized by the Department of Emergency Medicine, Aarupadai Veedu Medical College and Hospital, Vinayaka Missions Puducherry campus, in association with the Association of Emergency Medicine Educators, AEME, this international event is set to bring together global and national leaders in emergency medicine education. The Congress is being held with the valued encouragement of Honorable Chancellor, Dr. A.S. Ganesan, the Vice President, Dr. Anuradha Ganesan, Board of Management Member, Mr. Suresh Samuel. Their vision and support have paved the way for this extraordinary gathering for Puducherry WCEME 2025. It represents a historic first. Never before has the city witnessed such a large-scale academic congregation. Renowned 13 specialists from the United States of America, United Kingdom, Israel, Dubai, and 70 experts from prestigious Indian institutions such as PGI Chandigarh, AIMS Rishikesh, AIMS Raipur, JIPMER, and other centers of excellence enrich the scientific program with their vast knowledge. The event was formally inaugurated by Honorable Chief Minister of the Union Territory of Puducherry, through N. Rangasamy. WCEME 2020 promises a dynamic blend of training and scholarly exchange with participation that are 800 delegates in the 2 days, devoted to 10 hands-on modules and 2 days of plenary sessions, keynote lectures, panel discussions, and the presentation of 75 scientific research papers. The academic vision of WCEME 2025 is being driven by organizing chairman Dr. Arunachalam Einstein, Dr. L.L. Rajan, organizing co-chairperson Dr. Kabilan, Dr. Ashima Sharma, and the organizing secretary Dr. Naveen Puttam, whose leadership and dedication have been central to uniting distinguished educators, clinicians, and researchers on a common platform. WCEME 2025 is more than a conference. It is a milestone for Puducherry and for emergency medicine in this part of India, setting new standards in global collaboration, academic innovation, and professional training. Thank you.
Thank you, sir, for giving an overview of this Congress WCEME 2025. Now, it's my privilege to welcome Mr. J. Suresh Samuel, Member, Board of Management, VMRF, to share his valuable thoughts on exploring the new opportunities in and related to the field of emergency medicine.
Thank you, Dr. Manju. Honorable Vice President of Vinayaka Missions Research Foundation, Dr. Anuradha Ganesan, global educators from Boston, Seattle, Israel, United Arab Emirates, UK, distinguished national educators from AIMS and other national institutions from India, the head of the institutions from Vinayaka Missions Puducherry campus, learned academicians, researchers, innovators of medical education. Very good morning to all of you. It's a wonderful opportunity, the head of the state of Puducherry, to come here and inaugurate this World Congress on of Emergency Medicine and Educators 2025. This conference is first of its kind, I suppose, where we have so many global educators coming here, working on this 2 to 3 days of workshop, and also with the academic delivery on the latest innovations with emergency medicine. I thank Dr. Kabilan and also Dr. Einstein in orchestrating this international level conference, bringing together the global educators, which gave India an opportunity to look in terms of some of this latest innovations, the research and the clinical practices advanced in the field of emergency medicine. Vinayaka Missions Research Foundation is a deemed to be university, and we have 4 medical schools, and this is one of the campus. So we have other medical schools in Salem, Karaikal, and each campus has this medical school supporting academic program and delivering academic program and research programs. In a year, we have close to 600 undergraduates in medical education and around 300 postgraduate in medical education who pursue higher education in Vinayaka Missions Research Foundation. Said that, our focus has always been in terms of ensuring our academic delivery is quite comprehensive. Our academic delivery, like what Chief Minister of the State said, the quality of the academic delivery is of prime importance. And we also ensure that we try to bring in competency-based medical education, which helps in terms of learning some newer competencies and skills. And that is what we have seen during this pre-workshop and also in today's conference, and we are going to see tomorrow as well. And we also focus, apart from academic delivery, on qualitative. Our focus on multidisciplinary research is also on the higher side. We collaborate with global partners. In fact, we work on digital pathology, on how investigations can help in terms of more towards precision medicine. We also work with regard to liquid biopsy, creating organoids, and working on precision medicine. The reason I'm highlighting all this thing is the focus on multidisciplinary research is one of the important focus area. And in this campus, we have established the Center for Artificial Intelligence and Medicine. All these second year MBBS students go through a 30 hours of artificial intelligence orientation, which will help them to further extend for another 30 or another 60 hours and go to the extent of creating some algorithms from a medical education standpoint. So that is the focus that we have on multidisciplinary research. Coming with global collaboration, we always try to see how we could enhance our network, engaging with global partners, which brings in a better global care delivery system. We work with few of the US and other universities. We have a very strong relationship with MD Anderson. We are working with few universities in Japan and Taiwan, and also with a couple of them in Americas and also at Europe. So that brings in an opportunity for our students, faculty, our researchers to work on this newer global emerging areas, be it in technology-driven medicine, digital medicine, and likewise. The last point is our quality of care, the care delivery we provide. It is always our first focus. Today, this workshop, this conference is also will help us to enhance our care delivery, the quality of service. As a next step, we would be establishing a center of excellence in emergency medicine in this campus, which will support the people of the state in Puducherry and also at national at large. I wish all the participants a great going in this conference and all the very best. Thank you.
Thank you, sir. Thank you for sharing your novel and very innovative ideas and opportunities for global collaboration. Hope this World Congress of Emergency Medicine Educators will bring us, our university and our institute, more global collaborations. Your insights on multidisciplinary research and AI in medicine is thought-provoking. Thank you, sir. We are delighted to present the conference Sovenir. It's a reflection of the collective efforts, achievement, and spirit of our emergency medicine fraternity. It stands as a lasting record of knowledge, innovation, and collaboration being celebrated at this conference. To mark this special occasion, we now invite Dr. Anuradha Ganesan, Honorable Vice President, VMRF, for the release of the Sovenir and to address the gathering. I request the dignitaries to receive the Sovenir. Thank you. That's a proud moment for the organizers. I now invite Dr. Anuradha Ganesan, Honorable Vice President, to address the gathering.
Good morning, dignitaries of the dais, distinguished international faculty from the USA, UK, Israel, Dubai, Abu Dhabi and beyond, our eminent dignitaries from across India, faculty of AVMC and dear students. It is with immense pride and joy that I stand before you today to have released a souvenir of the World Congress of Emergency Medicine Educators here at AVMC, the WCEME 2025, a landmark conference that brings together some of the brightest minds in emergency medicine. For Puducherry, this is truly a historic occasion, the first time such a vast and diverse academic assembly in emergency medicine is being hosted here with over 400 delegates, 13 international faculty, and 70 distinguished national faculty from premier institutions like PGI, AIMS, JIPMA, and others. This Congress sets a new benchmark for academic excellence in our region. Emergency medicine is a discipline where seconds save lives. This 4-day conference with workshops and plenary sessions, the 75 research presentations, and the interactive panels are not just academic exercises, they're investments in better preparedness, sharper skills, and stronger systems to respond to crises that arrive without warning. The souvenir we release today is not just a record of this conference, but a legacy document, one that captures the vision, expertise, and collaborative spirit of this gathering. It will serve as a resource and an inspiration for students, educators, and practitioners long after these 4 days are over. As we celebrate this gathering, I am reminded of a timeless truth from the Tirukural written over 2,000 years ago. Utran alavum pini alavum kalamum katran karudi chayal. This Kural is found in the section on medicine, Marundu, highlighting that a doctor must take into account 3 vital aspects before administering treatment: strength, age, and circumstance of the patient, the severity, stage, and nature of the disease, the timing and season related to treatment. Only when these 3 are considered together, the physician's action will align with wisdom and medical science. How profound is this, and how relevant to emergency medicine, where judgment, timing, and skill come together to save lives? I wish to place on record my deep appreciation to the organizing team led by Dr. L. Rajan, Professor Ashima Sharma, Dr. Naveen Puttam, and the entire team of emergency medicine faculty, the team from the international team present here. Your tireless efforts have brought together this constellation of experts from India and abroad. And I do hope all our guests from abroad have had a satisfactory experience here in India and in Puducherry. The ancient Sangam philosopher Kaniyan Poompundranar, nearly 3,000 years ago, declared in the Purananuru, Yadam Ure Yavarum Kelir, to me, every land is my land, every person is my kin. Here we have with us a truly global family of emergency medicine educators coming together, united in purpose, transcending geographies, and working for the well-being of all humanity. On behalf of Vinayaka Missions Research Foundation and AVMC, I congratulate every contributor, every participant, and every supporter. May this conference not only strengthen emergency medicine in India, but also stand as a pillar of academic excellence and global partnership in the years ahead, and stand as a guiding light of innovation and preparedness for the future. With these words, I once again extend my congratulations on the successful release of the Sovenir of WCEME 2025. Thank you very much.
Thank you, Madam, for your valuable insights, and it was highly inspiring how great minds come together in this conference, and it has been a very successful event. It's now a moment of great pride to honor a few of our distinguished international faculty members from the field of emergency medicine, whose exemplary contributions to patient care, clinical excellence, and academic advancement have left a lasting impact across the borders. Their dedication not only elevated the standards of emergency care, but also inspires future generations of physicians to embrace innovation, compassion, and global collaboration in saving lives. Now I invite our Honorable President, Dr. Anuradha Ganesan, to do the honors, and I would like to call upon the international faculties of distinguished Dr. Ahmad Nama, Founder, AEMS Academy, Head of Emergency Medicine Department, Jury and Sydney Sword Center for Emergency Medicine, Hadasha University Hospital, Ein Kerem, Jerusalem, Israel. Thank you. Dr. Bala Miklos, Director of Trauma and Acute Surgery, Hadasha Hebrew University Medical Center, Jerusalem, Israel. Dr. Tamer Al-Shouha, Consultant STA, Thawam Hospital, Clinical Trauma Lead, A Region, Seha European Trauma Course Director, Life Support Instructor. Dr. Mohan Kopuravari, Consultant in Emergency Medicine, American Hospital, Dubai, United Emirates. Congratulations, sir. Dr. Susan Lee, Assistant Professor of Emergency Medicine at Tufts and Emergency Medicine Physician at OL General Hospital, Boston, USA. Congratulations, Dr. Susan. Dr. Gisa Hai, Fellow of the American College of Emergency Physicians, Assistant Professor of Emergency Medicine, University of Massachusetts, Milford Regional Medical Center, EMS Medical Director, USA. Congratulations, Dr. Gisa. Dr. Jeffrey Hooker, Associate Professor, Emergency Medicine, University of Massachusetts, USA. I request all the dignitaries also to join for the awarding ceremony while doing the honors. Congratulations, Dr. Jeffrey. Dr. Rotsover Young, Clinical Assistant Professor of Emergency Medicine, Tufts School of Medicine, Boston, USA. Congratulations, ma'am. Dr. Venkat Kotam Raju, Consultant in Emergency Medicine, Royal Derby Hospital, London, United Kingdom. Congratulations, Dr. Venkat.
Now, it's our privilege to acknowledge and recognize our illustrious national faculty members whose dedication to advancing emergency medicine, commitment to academic excellence, and tireless service in patient care have significantly strengthened the healthcare landscape of our country, India. So now I call upon the faculty from India. First, Dr. Navneet Sharma, Professor and Head, Division of Acute Care and Emergency Medicine, Post Institute, Chandigarh. We'll go to the next set. Now I call Dr. Nair Jamshed, Additional Professor, Department of Emergency Medicine, All India Institute of Medical Sciences, New Delhi. Okay. Dr. Sharbari Swaikas, Professor and Head, Department of Emergency Medicine, D.Y. Patel Medical College, Pune, Maharashtra. Dr. R.K. Singh, Professor and Head, Department of Emergency Medicine, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Uttar Pradesh. Dr. Nair Jamshed, Additional Professor, Department of Emergency Medicine, All India Institute of Medical Sciences, New Delhi. Dr. Chandni, Professor and Head, Department of Emergency Medicine, Government Medical College, Kozhikode, Kerala. Dr. Nidhi Kele, Additional Professor and Head, Department of Emergency Medicine, AEMS, Dr. Nidhi Kele. Congratulations to all the awardees. Now we have arrived at one of the most prestigious moments of this program, the conferment of the AEME Fellowship Convocation and the presentation of FAEME Awards. These honors are a tribute to the extraordinary contributions made by stalwarts in the field of emergency medicine, research and education. AEME is a non-profit organization whose vision is to promote excellence in emergency medicine, including trauma, and in turn to help all get quality medical care. AEME takes pride in its dedicated team of healthcare professionals, including highly skilled physicians, surgeons, nurses, and support staff who are all committed to providing personalized care, employing evidence-based practices, and staying abreast of the medical advancements. So before we confer the convocations, which requires a few minutes, so let me tell some highlights about this WCEME World Congress of Emergency Medical Educators that has happened in the last 2 days and today. So highlights include the workshops on focus, ventilation, cadaveric procedures, pediatric emergencies, toxicology, suturing and splinting. There were master classes and symposia covering trauma, neurological emergencies, toxicology, and disaster readiness. There were scientific sessions on resuscitation, cardiopulmonary emergencies, infectious diseases, control, sepsis, and acute care. Student pathways for undergraduates, postgraduates, nursing, and allied health sciences. There were also plenty of interactive panels that bridges the classroom knowledge with real-world applications. So emergency medicine is not just about responding, it's about preparing, adapting, and leading. WCME 25 embodies this spirit by creating an environment where knowledge meets the skills, practice, and where participants gain skills that directly impact patient care. By emphasizing learning by doing, this Congress strengthens the hands-on competencies of healthcare professionals, builds teamwork between doctors, nurses, and allied health staff, provides international exposure for Indian delegates and global visibility for Indian institutions, encourages research, collaboration, and academic exchange. With participation from distinguished faculty worldwide, WCEME 25 promises to be a transformative milestone in emergency medicine education, shaping the next generation of lifesavers. With this highlights what has happened in the last 2 days in our WCME, the workshops, and all the other academic activities. Now we move on to the next AEME Fellowship Convocation and FAME Awards. May I now most respectfully request the Honorable Vice President, VMRF, Dr. Anuradha ma'am, to come forward and do us the honor of felicitating our distinguished awardees. The Association of Emergency Medicine Educators, AEME, takes immense pride in recognizing actually 4 eminent doctors whose dedication, innovation, and leadership have left an indelible mark on the medical fraternity. Today, they will be conferred with the prestigious fellowship of AEME, FAEME. May I invite the first awardee, Dr. Nair Jamshed, now working as Additional Professor, Department of Emergency Medicine, AIIMS, New Delhi. Please come forward. And we request Arunachala Mainstream sir and Kabilan sir to come forward and please do the honors along with ma'am. Next, I invite Dr. Prakash Ranjan, Associate Professor, Department of Emergency Medicine, All India Institute of Medical Sciences, New Delhi, to come forward and get his fellowship. Now we have Dr. Ashray V, who is a consultant in emergency medicine at Aster Whitefield Hospital, Bangalore. Now the last person is Dr. Sangeeta Sahu. She is unable to reach here because of the delay in her flight, but I just announced it's Dr. Sangeeta Sahu, Additional Professor, Department of Trauma and Emergency, AIMS Bhubaneswar. She has not reached, so let's applaud for her too. So congratulations to all the awardees.
Thank you all. We now arrive at the most awaited moment of this program, where we honor excellence, dedication and an extraordinary contribution to the field of emergency medicine. The Distinguished Emergency Physician of the Year Award 2025 is being conferred upon a doctor whose commitment, compassion and clinical expertise have saved countless of lives and set the highest standards of emergency medical care. The World Congress of Emergency Medicine Educators, WCEME 2025, proudly presents the Distinguished Emergency Physician of the Year 2025 award to Dr. Ashima Sharma, Senior Professor and Head, Department of Emergency Medicine, Nizam's Institute of Medical Sciences, Hyderabad. It's my privilege and honor to invite our Honorable Vice President, Dr. Anuradha Ganesan, to do the honors. This award is awarded to her in recognition of her visionary leadership, pioneering contributions and unwavering commitment to advancing emergency medicine in India and across the globe. Dr. Ashima Sharma has been a trailblazer in academic emergency medicine, establishing the first MD and PhD programs in the speciality at NIMS Hyderabad, mentoring generations of emergency physicians and shaping the future of pre-hospital and in-hospital emergency care. Through her extensive research, global collaborations and service with international organizations such as ILCOR, she has elevated the standards of education and scientific inquiry in the field. With deep admiration and gratitude, WCEME proudly honors Dr. Ashima Sharma with the Distinguished Emergency Physician Award of the Year 2025 for her lasting impact on the growth of emergency medicine. Madam, today we celebrate not just only your award, but also the years of dedication, compassion and unwavering service you have given to the humanity. Your journey as an emergency physician has been marked by courage, quick decision making and a deep commitment to saving lives in the most critical of the moments. The Distinguished Emergency Physician of the Year Award 2025 is a true reflection of your excellence and leadership in the field. On behalf of the entire fraternity gathered here today, we extend our heartfelt congratulations to you, Dr. Ashima Sharma. We wish you continued success, health and strength in carrying forward your noble mission. Thank you, ma'am. I request the entire gathering to give a standing ovation to Dr. Ashima Sharma. Thank you all. That was truly inspiring. Thank you, ma'am.
Congratulations, ma'am. Expressing gratitude is essential as it acknowledges the collective efforts that made the event possible and leaves the gathering on a note of warmth and respect. To formally express our gratitude, may I now invite Dr. V. Edulrajan, Organizing Chairman National, WCEME 25, to deliver the vote of thanks.
Good morning to all. On behalf of Vinayaka Missions Research Foundation, Deemed University, and Aarupadai Medical College Hospital, Puducherry, it's our distinct privilege and pleasure to offer the sincere vote of thanks. We begin by extending our proud gratitude to our esteemed Chief Minister, Shri Rangasamy, for graciously accepting our invitation and honoring us with his presence and participation in WCEME 25 program. Your support is blessing and lends immense prestige to our efforts, sir. Our grateful thanks to our Chancellor, Dr. A.S. Ganesan, whose unwavering vision and commitment continuously inspire and encourage us to elevate AVMC to a world-class standard. Your support and instrumental in success of conducting WCEME 25 program, sir. A very special expression thanks to is also due to our Madam Chancellor, Dr. Anuradha Ganesan, whose constant encouragement foster positive changes and promotes as a spirit of excellence across all our endeavors. We are deeply grateful to Mr. Suresh Samuel, Member of Board of Management, for his steadfast and constant support in realization of the WCEME 25 program. Similarly, our thanks to our Dean, Dr. Mani, for his valuable insight and constant support. Our sincere appreciation is extended to Dr. Ashima Sharma, the organization core chairman, for her meticulous planning, dedication, and vital support in successful execution of this event. We extend our special thanks to international faculties who travel a great distance to spend their valuable time and knowledge, sharing their expertise with the younger generation. Their insight enriches all. Our national faculties who journeyed from across our country to join us here for WCEME 25 at AVMC. We offer our deepest gratitude. Thank you for generously sharing your invaluable experience, which has been tremendously asset to this program. Our appreciation also goes to Dr. T. Prasad, TNMC Observer, for overseeing and guiding conducting this program. The flawless execution of the event is magnitude is a result from dedicated teamwork. A profound thanks extend to the entire organizing team who meticulously planned, organized, and conducted every facet of this event with precision and skill. To the delegates, the very reason we gather here, our success is truly an impossibility without your enthusiasm and participation. Thank you for making this event so vibrant and meaningful. We also offer a special commendation to the audiovisual electrical team for ensuring the seamless technical operation of this entire program. Thanks to the press person for this coverage and support. Thanks to the catering team for the exemplary service. And a warm vote thanks to the ground staff for their dedicated and indisputable effort. With these words of sincere gratitude to every person who played a part, we bring this ceremony to a close. Thank you all once again.
Thank you, sir. Ladies and gentlemen, may I request you all to rise for the national anthem. Thank you all for being a part of this memorable inaugural session. We look forward to your active participation in the upcoming sessions of WCEME 25. Hope you all had an academic feast, and thank you once again. And I request all to join for the high tea which is served very next to this Ganesan Learning Center 1. And I request all of you to assemble in the respective venues for the scientific programs after 15 minutes of taking a break. Thank you. One minute.
Of the cardiac myocytes. The dose in pulseless patient is 300 milligram IV bolus followed by 150 milligram after 5 minutes, and in patients with pulse the dose is 150 milligram IV